Tsyganova. I'm a medical coordinator from Patient Support Center Bookimed. And this is Moshe Inbar, head of the oncology department in Suraski Medical Center, Tel Aviv.
Still the head of the department for the next 10 days.
For the next 10 days. Okay, great. And now we have some questions for you. Firstly, can you describe the work of your department?
I will start with what is oncology in Israel. Oncology in Israel means that the head of department of oncology is also responsible for the radiation therapy department. I don't know how it is in Russia, but in most of those third world, it's completely separate. Radiotherapist or radiotherapist, chemotherapist or chemotherapist. In Israel, it's still as it was 40 years ago, because we didn't have enough radiation oncologists. So this is one profession. Although now there is a subdivision. They start with oncology, general oncology. I'm the tutor for both of them. But under me there is a chief of radiation therapy. But I'm his chief. Formally I'm his chief. Practically I'm not his chief. Because he is doing radiation therapy. All the troubles are on me, all the success are with him. Now, there are in Israel 19 units of oncology. 6 big, the Tel Aviv Suraski Medical Center, the Shiba Medical Center that is 60 kilometers from here, the Davidov Medical Center which is 20 kilometers from here, 3 in the center. There is the Dassat Jerusalem, where I graduated about 45 years ago. There is the Rambam in the north of the country, and there is a smaller one, but still big, in Beersheba for all the south of Israel. All these 6 centers has radiation, chemotherapy, their own inpatients and outpatients. They have all the 4 facilities for oncology. Another one is a Sutem, Tel Aviv, which is a private hospital that I'm going to chair for the next 5 years since October. They have an excellent radiation unit, they have an excellent outpatient chemotherapy unit. They don't have an in-bed department of their own that I'm going to change, and they have a lot of patients. And the people who are doing oncology there are my experience, so I think they're very happy to receive me back as their manager. Now, what is oncology then? Our department, has got about 4,000 new patients a year, 4,200 from all kind of cancers except hematology. Leukemia is treated by hemato-oncologist. Lymphoma are treated by hemato-oncologist, and myeloma are treated by hemato-oncologist. The moment they need radiation, they receive it in our department. So the double booking is 2 different patients. Most of the patients in my department, because I'm a breast cancer specialist, we have got about 800 new breast cancer patients a year, which is 20% of the new breast cancer in Israel. We've got about 1,000 of gastrointestinal oncology, including colon, pancreas, stomach, esophagus, anus, rectum, gallbladder, hepa. We've got about 400 sarcomas a year. It's very, very large amount of patients because we have special surgeries for sarcomas, and my deputy is the oncologist who is taking care of them. So it's about more than half of the patients in Israel with sarcoma that are treated. And all the others are gynecology and the neck, a large department of CNS tumors, because a very famous neuro-oncologist is working in the department. We cover all of them.
And you have a lot of foreign patients right now.
We had, when the ruble was 28 ruble a dollar, a third of the patients in the outpatient was from Russia. When now it is 74 or 75 of the dollar, diminished by half, about by half.
And what are the most frequent disease what is the most frequent diagnosis among the foreign patients at your department?
Look, some are coming to me because of my name in breast cancer. So I'm very famous in the internet in Russia. But they're coming asking, do you want to see Inbar for the breast cancer? As I treated Abdulov some years ago for lung cancer. They are also, it was on the internet in Russia, and the doctor of this famous actor, singer, I don't know. So they're coming from me also for lung cancer, and the others are mainly gastrointestinal. And what we don't see very often in Israel, and I see very often from Russia, is cervical cancer, which is a very rare disease in Israel. In Israel, we have 150 new cases of cervical cancer. I see from Russia 1 a week cervical cancer. That's the most of them. The others, the agents that are, they know. The moment they have a patient with brain tumor, I want them to see my neuro-oncologist. I don't want to see them. He knows better. When they're asking about the sarcoma patients, I want him to see my deputy because he knows better. When I have a head and neck patient, not complicated, when you need my experience, you know. But when it's a first stage, second stage, with the common practice of radiation and plus minus chemo, I want them to see my head and neck specialist. So the most of them, breast, lung, lung cancer.
Okay, and could you tell me about the mistakes of diagnostic? Because I know that some percent of foreign patients had this problem with...
Look, all of us are doing mistakes. Me too. The only one who doesn't make mistakes is the one who doesn't do anything. We make mistakes. But only this morning, I've seen a patient 2 weeks ago from Russia, breast cancer, asking her agent to see Inbar urgently because she's developed lung metastasis 12 years after the diagnosis of breast cancer. Asymptomatic completely. She doesn't know what to do. They performed a CT on her. I don't know if it was Ukraine, Uzbekistan, I don't remember. Russia, Moscow, I don't know. And some lesions were found. No cough, no respiratory distress. She was on hormonal treatment, it was stopped. And they want to replace it by chemotherapy. She said, I want to see it. I've seen the patient, I've seen the CT. Yeah, there were some findings, new. All tumor markers were fine, she was fine. And I told her, look, I don't know your financial problems, but if you are an Israeli citizen, the first step was to do a lung biopsy. Not to decide for 12 years that you have metastases that were found unnecessary, because we in Israel, we don't perform a CT for a healthy patient. Never. Minimum. She couldn't afford the shekel. On Friday, her agent sent me the report. She's got tuberculosis. She phoned me this morning. How did you know? I didn't know that you have tuberculosis. I knew that after 12 years, in an asymptomatic patient, you have to prove what the patient is. That's the mistakes. Don't take anything as granted in medicine. It's very easy to combine a patient with lung nodules to tell her, look, you received hormone therapy, now you deserve chemo. And if it was a metastasis, does she deserve chemo? Asymptomatic patient, you've got 4 more anti-hormones, Faslodex, palbociclib, estrogen, and progesterone, and then you only go to chemo if the patient is symptomatic. This is a mistake? Yes, this is a mistake. In Israel, it would not happen because we know first metastasis, you have to prove. Unless you have this combination of elevated markers, a symptomatic patient, a lot of new findings. But she didn't have anything. If she wouldn't have done this rubbish CT, she would have saved, I don't know how much she paid for the travel, for not being hospital, for the biopsy, but she lost a lot of money for nothing. For tuberculosis. And other mistakes, I will tell you, it's not mistakes. Russia and Ukraine, I don't know, have invested a lot of money in machinery. They've got a wonderful MRI star, a wonderful bed, a wonderful thing. They don't know to run it. We have the same problem with MRI of the breast. The government wants to buy now 25 machines. Yeah, but who will read the MRI of the breast? Now only 10 experts in Israel. So you buy 25 machines. If you don't teach people to read it, it's useless. So that's the problem in Russia. And another problem is not explaining to the patients that with a tumor of 1 centimeter or 2 centimeters in the breast, you should undergo lumpectomy, radiation, and mastectomy, and the results are the same. The other mistakes, but it's not mistake, but it's money problem. In Russia, Herceptin is not paid. I don't know in Ukraine for the adjuvant setting. So you see a patient with HER2-positive disease, 5 involved nodes. She received only chemo. Herceptin or then there is not. I'm telling the patients, I'm not asking them. I'm asking the financial status if they can afford it. Some of them can afford it. But tell the patient, look, we are a poor country. If you are rich enough and you want 20% more of being alive after 10 years, buy Herceptin for 1 year. That's a mistake. No, I don't know if it is a mistake or not. For us it is a mistake. But, the same with Avastin and Erbitux in metastatic colon cancer. They don't offer the patients biological. They don't perform KRAS. Then when the patient hears that he can have another biological, but I need the tumor in order to examine it, the tumor has disappeared. That's many times. The pathology lost the tumor. In Israel, it's a crime. So other mistakes are not mistakes. No, it's overdoing will be a better word. Not a mistake, but I think overdoing, believing in chemotherapy of 4th line, in pancreatic cancer, in lung cancer. They don't do all the new tests we are doing for biological because they cannot afford it in Russia. In Israel, we also cannot afford it, but we are telling the patient it exists. Where the form takes the money, it's not our problem. By law in Israel, we have to tell the patient everything we know. Otherwise, we are blamed as לתקוף, להזיק לו.
כן, כן. навредить.
You have to tell the patient everything you know about his disease. Now, for example, there is a new medicine for metastatic breast called palbociclib. you give it together with anti-hormonal therapy. You double the chance of responding. You double the length of response from 1 year to 2 years and 4 months. That's a lot. The cost of the drug is $15,000 a month. It's not reimbursed in Israel. No, not yet. It will be next year. But all patients in Israel know about it because we have to tell them. They have private insurance, private money under the, I don't know. We have to tell them. Otherwise, in Russia, they didn't hear about it. Only the clever patients who enter the internet are asking me about Embrace. Embrace is the name. When they hear the price, but some of them can afford it. Look, I've seen a patient from Kiev, I think, with a metastatic vulva. She received 3 lines of chemotherapy, none of them helped. And I've spoken to her, look, the only treatment I can think of is Keytruda. Keytruda is immunotherapy. There is no evidence that it works in your disease because no one tried it in vulva. But there are rumors about cervical cancer. It was approved for SCC of the lung. So by analogy, I'll try it for 6 cycles. She's now 1.5 years on the treatment. She spent already $150,000 American dollars. But there is no sign of disease. The woman came from 1.5 feet in the grave. She's asymptomatic, but she asked me, how long are you going? My money is running. I don't know what to tell her. Usually we give it for 2 years, so then we stop. So she didn't know about the drug, and that's the mistake. She had to know, she had to choose between to give the money to her daughter, son, the husband, I don't know, I don't care. And the option that there is a treatment, that the chances of responding are poor, but they are there.
Okay. And if talking about diagnostic of breast cancer, can you tell me about oncotype DX and mammoprint? In what cases we should use this diagnostic?
In Israel, we have the possibility to choose oncotype DX that is paid by all of the HMO. It's not reimbursed by the government. It's a bona fide of the HMO. 2 of them now let the doctors choose between oncotype DX and PAM50. PAM50 is Prosigna. It's the same thing, but examining 50 genes because it's PAM50. And in the private market, especially for tourists, we use mammoprint, which is a test from Rotterdam with 69 genes. That is half of the price of the 2 others. The most popular, because it's the oldest, is the oncotype DX. We use it, I use it. First of all, it's free in Israel. So we use it in every patient that is hormone receptor positive, that we know that should receive hormone therapy, and we are asking ourselves the delta, the benefit of adding chemotherapy to the hormone. There is an overuse because it's free. You are taking a patient with a 4 millimeter tumor, G1, hormone receptor positive, node negative, and are asking for oncotype DX. It would be low. The HMO will pay $5,000 American dollars to the agent in Israel. But the patient deserves to know that he can have it. I'm using it that it should be used young women with node positive, hormone receptor positive, at least in the group of not more than 3 involved nodes. I think it should be used in every woman, postmenopausal, with hormone receptor positive, never mind the number of nodes. The gain of chemotherapy there is very small, and if you can avoid it and the patient can pay it, just do it. I'm a big fan of this oncogenetic test.
And about surgery treatment of breast cancer.
Surgery?
Surgery, about mastectomy and lumpectomy. If the case, if the situation is good for both methods, what you choose to treat?
I think for the last 40 years, we know that lumpectomy plus radiation equals mastectomy. So why mastectomize the patient? Unless the patient tells you, I don't want to receive radiation therapy because I'm from Chernobyl. Nonsense. When the patient is telling you that she is not going to undergo radiation, either because it's very expensive or she lives in a farm 400 kilometers from Kiev, I don't know what, then you're obliged to offer a mastectomy. In Israel, we don't have the problem because everything is closed. Mastectomy are rarely done in Israel now. I'm a big advocate of non-mastectomy. We can turn almost every tumor from non-operable to operable by using chemotherapy, hormonal therapy, and biologicals like Herceptin, Pergentine, and so on. And I am now in a, in my age, in my position, I can be a bit, let us say, strange. I didn't invite this document. In patients, the tumor was like this, and it disappeared after chemotherapy or chemobiological, and it disappeared by physical examination, mammography, ultrasound, and MRI. I don't see anything. I offered them not to undergo any surgery, just operation. And everyone thinks I'm a bit crazy, but if you look into the literature of the Europeans 20 years ago, French women 20 years ago refused to undergo surgery when the tumor disappeared. So the oncologists were obliged to do something. They only knew it. The local recurrence was higher in the non-surgical patients, but the life expectancy was higher when they didn't undergo surgery. The English people from the Royal Marsden did a randomized study some years later. They have the same results. In England, in the Marsden, where my friend is working, Ian Smith, when they are achieving a complete response by chemo, they suggest the patient not to undergo any surgery, just to be irrigated. So I don't know of any woman, young, even old, that want her breast or breast to be removed. That makes no sense. It's a sexual sign. Even if it is not a sexual organ, it's a sexual sign. That's a body image, sexual image. So if you can do without mastectomy, without compromising the life expectancy of the patient, just don't mastectomy the patients.
Okay, and about statistic of treatment, for example, breast cancer, depends on the stage. What are the statistic of good treatment, for example, first, second stage, and the fourth, at your department?
We don't have the result of our department, but it's worldwide now. Between 25 to 30% patients are dying from breast cancer only. All the stage 4 are dying without exceptions, except some with HER2 positive disease that enter the complete response and they are kept on Herceptin. I've got 2 patients now with liver metastasis, one living 14 years and the other 12 years. I don't dare to stop treatment. The government allows me to go as I want. The patients are from coming to the hospital every 3 weeks. But when I'm speaking to them, and you ask me, do you like information? I don't tell the patient, do you want to stop? Do you dare to stop? They look at me and smile. So, see, the other patients that are living for years, some of them, are the bone metastasis only with hormone receptor positive. They receive tamoxifen, Femara, Rimidex, whatever. Patients now are 18 years after the histological proof of bone metastasis. It's not a bone scan, it's pathology. In stage 1, we have 90% of cure. Stage 1 means a tumor up to 2 centimeters with negative node, unless she's not a triple negative, which is a disease. And then stage 2 and 3, it's between 30 to 40 to 60% cured, depending on the number of involved nodes. Because in Israel we have a routine of mammography every year or every 2 years. We usually diagnose them in early stage, usually. If they are coming to the test, you cannot force anyone to do a test.
And about another oncology disease, in your opinion, what is the reason that for the last years amount of oncological applies increased?
Ask again.
In your opinion, what is the reason that for the last years amount of oncological applies increased?
Do you know the reply?
You think is it increased for the last years?
Yeah, but why?
I don't know.
Life expectancy, I don't know in Russia. Life expectancy is becoming too long. Let us say 2. We live now 80, 90 years. In the States, they will have 1 million people living more than 100 years in 2 years. You know what is 1 million people living more than 100 years? They will all have cancer of the prostate if you examine them. If you don't examine, you don't know. But everyone wants to have a PSA. Everyone. He's 95 years old, for heaven's sakes. He wants to have a PSA exam. What for? No, that's his right. Also in Israel, the family doctors are facing a problem. A 75 years old man who is still sexually active, or sexually active, at least better. He wants a PSA. You find a PSA that is higher than normal. You do a biopsy. The biopsy is positive for cancer. Then you're doing prostatectomy, radiation, castration. Well, the same with women with breast cancer. If you live to the age of 90 and you do mammography every day, you will find more cancer. That's the only reason. No other reason. We live too long. Yeah.
How do you think, is it possible that in the near future, oncology disease will be common and absolutely curable?
We estimate that in the year 25, not the song, the song is by whom? A famous song. There will be 60% of the population, 60, will be diagnosed with cancer. But 65% of them, 2/3, will be cured. That's the good news. The bad news is images.
Great. Thank you very much for your time.